Nysa Therapy Incorporated presents Healing Personality Disorders. Course number 2, Nysa Techniques. Lesson number 3, Esteem.
It is ethically and clinically appropriate to seek supervision or consultation before using any new technique in your practice of psychotherapy. Please contact us at nysatherapy.com if you would like to receive guidance from our highly experienced consultants.
Here is Dr. Stephen Diggs, Nysa Therapy founder and director.
Hello everybody, and welcome to our next lesson on Nysa Techniques, Esteem. And Esteem is a very serious part of Nysa Therapy. And the reason is that in the world of psychotherapy, there tends to be a split between some methods that are heavy on empathy, caring for and nurturing the pain of the patient, and that would be relational therapy. Some methods that are heavy on esteem, respect, compliments, and that would be solution-focused therapy. And what we've done, of course, you know the drill by now, we've put those two together. So our last lesson was on empathy, and what you're going to see is how they fit together, how you need both of these things. Because if you're just doing empathy, then you end up going over and over again the patient's pain, and this can be very repetitious. It can take years and years, and very little can happen as you keep empathizing with their pain, and they get stuck in that pain. They need empathy, but they don't need to be stuck in it. And if you're just doing esteem, oh, that's great you did that, that's great you did that, patients get very frustrated because they feel like their problems and their pain aren't important and they don't matter. And we have to heal and deconstruct the defenses built around that. So we've got to have both. You had empathy last lesson, and today it's going to be esteem, starting with the 6 steps of esteem. Step number 1, identify the PD. Get a sense of what personality disorder you're dealing with at this given moment. Identify the exception. What's the opposite of that PD? What's the thing that's different than that PD? Number 3, search your positive feelings. When you see that exception and you witness it in front of your eyes and the patient's telling you a story and you hear that they've done something remarkable, well, you're going to have positive feelings. Search those feelings, wonder, understand what it is you're actually feeling. Then, tell your patient how you feel. Say it out loud. Steve Diggs, I feel this way about what you've done. Make it personal. Then, ask, did you let that in? Did it penetrate your walls, your boundaries, your defenses, so it could enter into your heart and help to change that pain built defensive fortress that you've made? And then, because most of our PD patients cannot let it in, you negotiate that internalization. You try to get to that point. Now, if you're paying attention, you've noticed that steps 4, 5, and 6 for esteem are identical to steps 4, 5, or 6 for empathy. That's right. These two gifts, these two, desires that we have for our patients of both caring for your pain and noticing how remarkable you are, those two things have to be let in very similar ways. It's me as a human being, you as a human being, and I have something to give you, and it's going to help you, but you have to let it in. Now, when to use esteem? You can use esteem whenever your patient presents an exception to their DSM-PD criteria. Anytime you see that, you can esteem them. And sometimes we make a very big deal out of this because we need that patient to start noticing their competencies, noticing their power, noticing their activation. So we'll make a big deal until we get there. Other times, it's not such a big deal. It can be, wow, that was nice. Okay, what else? But what we're doing when we use Esteem is we're teaching, training, sensitizing the patient to know that this is a therapy in which your competencies, your innate, inborn competencies are going to be noticed and they're going to be appreciated. So, step number 1, identify the PD. What's the first step? Don't be afraid. Learn the DSM criteria for the 12 Nysa Therapy PDs. And what does this mean? It means that there are 7 to 9 criteria for every PD, and you should know them very well. This takes years and years to do. You can study and cram it in your head, not a bad thing for you guys who are students who want to really learn stuff quickly. But most of the time, you have to learn it over time and make it functional, make it usable. So don't panic on this one. That being said, here are the 12 personality disorders that we are inviting and encouraging you to learn the criteria of: borderline, avoidant, schizoid, masochistic, antisocial, narcissistic, paranoid, schizotypal, dependent, obsessive-compulsive, passive-aggressive, histrionic. So, I've been doing this a long time. I still don't know all of them. I know most of them pretty well, but don't pressure yourself about that. You'll learn it over time if you get into this line of work. Next, and this is important, we want you to get back to that state of mind we encourage you to have when you are empathizing. We want you to sink into your connection with this human being. Observe them, feel them, think about them, get connected, wonder about them, and in that connection, in that involvement, identify one or more of the PDs that they're exhibiting at that moment. But it's not just a head game. It's not just thinking about, oh, which of these criteria do they meet? It's also about your connection. Your connection tells you so much about what this person is struggling with, what PD they have. And it also tells you where you're most likely to find the exceptions. Keep in mind the identified PD criteria. Use them to look for the opposite. Right? So if I know and you know that borderline people have trouble managing their anger, excessive anger, angry relationships, if you have that PD criteria in mind when you're working with a borderline patient, then as soon as they say, I wanted to get mad, but I didn't let myself, you can say, hey, there's the opposite of that criteria. And you can jump right in. Hi, Sarah.
Hello.
So good to see you again. How have you been doing?
Horrible. I can't get out of the house. I've just been so depressed.
Mm-hmm. Yeah, I see that. I'm very sorry. How's your inner dialogue? How is your talk to yourself? Negative, positive? What's it like?
It's horrible. I just feel ridiculous and lazy all the time.
Okay. I'm very sorry.
Yeah.
So, what I'm doing is I'm identifying the personality disorder that she is in. Also, obviously, I'm full of empathy, but I want to get a sense of what she's in so that I can start looking for the opposite. And she's depressed, she's shut in, and her inner dialogue is horrible. She attacks herself for being ridiculous and lazy. Those are all clinical signs of avoidant personality. And so She may have other personality disorder positions that she moves to at different times, but at this moment, she is in avoidant personality disorder, so I'm going to look for the opposite of that so that I'll be able to esteem her. Step number 2, identify the exception. You're going to identify which personality disorder they are using to protect themselves, and then you're going to identify the exception to that PD. So, learn the Nysa Therapy list of common exceptions for PDs. What we've done for you, and you'll be happy to hear it, is for every criteria of every personality disorder, we've given you an example of common exceptions. So, under the criteria for the borderline patient has frantic efforts to avoid real or imagined abandonment, we've said the patient is peaceful and competent while you're on vacation, for example. Common exception. So you learn that list, it'll get your head in the game too. One of the things we like about that list is it gets you thinking about exceptions. It gets you thinking that exceptions are always there and they're real, and you get a sense of kind of the grounded behaviors and attitudes that the exceptions have. Listen and look closely for the opposite. Let your feeling and intuition guide you. Now, this is important because, yeah, you got to think. You're a smart person. You've got degrees. You got to think. But so often, what really lets you in are your feelings and intuition. So, for example, you're sitting with that person and you know they're borderline because that's how they came in. Suicide gesture, cutting, alcoholism, so you know this, but you're feeling them, you're getting connected to them, and all of a sudden it doesn't feel borderline. It doesn't feel quite right. And so you go a little deeper into your intuition and it hits you. Oh, they've shifted into an avoidant position. Wow, well, what's the opposite of avoidant? Well, that's kind of risking being judged or criticized. And so they keep on talking, and you notice that they're being very forthright with you, but they're not all full of energy. They're kind of down and a little sad and hurt. And you're able to say, I'm really happy and I feel a lot of respect for you that you're able to tell me so many of these tender and painful details about how you were hurt. And they say, oh, thank you. I've wanted to tell you, but I've been so afraid to tell you. No, you're doing great. You're getting to where we really need to go. I'm just feel a lot of respect for you. Okay, I didn't know if I was doing it right. Now, if you were just using your head and thinking, oh, we've got borderline, you might go into a place that shuts them down more. But now you sense they've moved to that avoidant position, which is a common thing borderline patients do, by the way. Connect to their pain and struggle. Now, this is a way we throw out the book. We throw all that out. You're just going to connect to their pain and struggle the same way you would if you were connecting to their empathy. And you're going to imagine that opposite. And you connect with that pain and struggle, and you feel this person who is lonely and sad and isolated, and then they tell a story about how they're thinking about going online in order to, perhaps start dating, and wow, you got it, because you were imagining them taking steps to come out of their loneliness, their isolation. You imagined that. So as soon as they say that, you can connect to that and you can esteem that because you let yourself feel what the opposite of their pain and struggle was. Now, very important, identify exceptions in your patient's narratives. So they're going to tell you stories. I did this, I did this, I did this, I did this, I did this. And you're going to look for and listen and hear those exceptions in their stories. And when you hear them, we want you to esteem. But you're going to actually notice them do exceptions in their relationship with you. You're going to notice that. And these are some of the most powerful exceptions there are. When something happens between you and your patient, you notice it and you bring it up. So you're working again with a borderline patient, and they, they say, well, my boyfriend, blah, blah, blah. And you'll say, oh, is that William? And you can see them about to get enraged because William's their old boyfriend. They've got a new boyfriend now, and you didn't remember. No, my new boyfriend is Stacy. Okay. And I might say, boy, you almost got really mad at me because I screwed that up, didn't you? And I'll say, yeah. I'll say, well, but you didn't. I mean, that's pretty impressive you didn't get mad at me because that's kind of a big screw up on my part. On the side, borderline people like you to remember the names of their boyfriends, girlfriends, sisters, brothers, dogs, animals, goldfish. They like you to know their world and have your hands in it, right? And say, well, I'm really sorry I did that. That was wrong of me. That's okay. But how did you do it? How did you not get mad? Well, I just thought, am I going to waste time in therapy when I could get better just because you made a stupid mistake? No, I want to use our time for something productive. Wow, that is a great thing that just happened, right? We can esteem that because they did something very different, and there it happened right in front of you. And it's very powerful. And you get the added advantage of being able to say, I'm sorry, and apologize, and take care of their feelings for the mistake you've made. Because very often, our patients did not get their caregivers apologizing when they made a mistake, making amends for that. So it's a win-win right there. Notice when you have positive feelings, respect, happiness, pride about what your patient did. So you may not even be thinking about the criteria. You may not even be thinking about the opposite. You may not even be doing any of that stuff. You may just be sitting there with them, hearing a story they have, and then all of a sudden you feel like, wow, that was cool. And if that feeling comes up in you, most of the time it's going to be because it was an exception to past presentations that you've noticed about them. So you notice it, and you're sitting there and you notice something good, and you say, wow, she didn't get mad at me. That felt pretty good. I thought she was going to get mad at me. And that positive feeling alerts you to when you've got an exception. Oh, God, Sarah, I am so sorry you're suffering this much. I can see it in your face, and I'm really sorry. So, were you able to get out at all?
I went to the store to get food. I was out. I went around midnight so nobody would see me.
Yeah. That's so tough. And how about your sister? Have you talked to her? Or?
Yeah, we went out to lunch the other day. We had Thai food.
Really?
She doesn't judge me like everybody else.
Right. She doesn't judge you, but it wasn't delivery. She didn't have it delivered to the house. The two of you went out together?
Yeah, we went out together.
What restaurant did you go to?
Oh, I think it was on 2nd and Broadway. It was downstairs. It's a nice place.
Okay. Well, I was looking for the exception, and there it is. She went out and had Thai food. Now, what's important to notice is that she doesn't register what she has done. In her mind, she's a loser, she's ridiculous, she's lazy. she doesn't register that she's done something exceptional because she sees her life and her behaviors through the lens of feeling lazy and ridiculous and horrible all the time. So I see what she's done as a remarkable exception, but I've got to help her to see what she's done as a remarkable exception. But in this step 2, what I've done is I've identified the exception, and it is big, and I'm going to go after that thing. Step 3, search your positive feelings. What we want you to do is search and discover your genuine positive feelings about the exceptions to criteria that you're seeing your patients display. When they do something different than what they've done their whole life, you're going to have positive feelings about it. You should have positive feelings about it. And these are people who have suffered immensely throughout their life. Horrible suffering. It is such a painful way to live with personality disorder. It is so painful. And suddenly they're doing something different and new that is on the road to a new life for them. It thrills me to this day. I get excited. I get thrilled. My God, this patient of mine who has suffered so much is taking some steps in the right direction. Just yesterday, I was with a patient and they took this remarkable step in the right direction. It's an older person and years, decades of struggle, and they did something very remarkable. And I was thrilled. Now, I had to be careful about how I presented it because they kind of don't like me being too peppy, which I can understand. But I still was able to kind of pull it in and say, wow, I mean, is it right? Or did I see you do something pretty exceptional there? And they said, no, that's really different for me. I said, well, I feel pretty good about that. How about you? And there was a pause, and I said, yeah, that's pretty good. I said, well, here we go. One more step. And they said, yeah, one more step. But inside I was alive. Now, those positive feelings you have are going to be different with each patient in each situation. They're going to be unique. And we want you to pay attention to them because we want you to know the uniqueness of that feeling. Because just like with empathy, if you're well connected, that unique feeling is going to fit that patient and that situation exactly as it should. And I really think I'm doing right when I'm in the zone enough that the same patient will present 2 different situations, both steps in the right direction, and I'll have very different feelings about each of those situations. That tells me I'm well attuned because I'm attuning to this particular situation with this patient. So what are the things that you might feel? What are the positive feelings you might feel when you go searching? You might feel impressed. That's what we say a lot. I'm impressed. But you might also feel respect, happiness, pride, encouraged, awed, stupefied, overwhelmed, excited, satisfied, right? You could feel all of these feelings are options of what you might feel. They're all positive feelings in response to this particular person and situation. And as I was just saying, if you're well connected, that feeling will be exactly what the patient needs from you, what they need to hear. So for example, we use impressed most of the time because the word pride can be a little condescending. Well, I'm proud of you that you did that. It can be kind of patronizing and almost feel like a put down. So we tend to say, I'm impressed with what you did, because it hands over more responsibility and you did this on your own. Not, I'm proud of you because I'm such a great therapist, I fixed you, but I'm impressed because on your own you generated this remarkable exception to your problems. But there are times I will feel pride in a patient, and I'll feel proud of them. And I've learned to kind of stick with that, but I'll say, are you sure you want to say that, Steve? Shouldn't you say impressed? And my feeling says, no, pride is the feeling, pride is the word. And I'll lean in and I'll say, you know, I'm really proud of you that you did that. And remarkably, almost every time they'll say, thank you, you know. My dad was never, ever proud of me. It means so much for me to know that you're proud of me. Thank you. And if I'd have turned that over to impressed, I would have missed that moment. Because I was well connected, I know to stick with the feeling I have. Okay then. What did you have?
Oh, it had vegetables and shrimp. It wasn't that spicy, so I liked it.
Okay. And I mean, weird question, but you ate the whole thing, or did you take some home, or?
I took some home.
And it tasted pretty good?
It was okay. I just didn't like being out. It just caused me so much anxiety.
Okay. Okay. Okay, very good. Now, step 3, I'm searching my positive feelings. So I'm biding my time a little bit because this is a big exception. So I'm kind of biding my time, asking a few questions, getting a few more details so that I can figure out how it is I actually feel. And she answers about the food. It was okay. I ask, did you eat it? Did it taste good? Because depressed people, with major depression, it's hard for them to enjoy, so she may not have enjoyed the food very much, but I wanted to see if she enjoyed it at all. Did she take some home? How good was her appetite? I'm just checking for other little things that might build into the exception. And what I arrive at is, it was horrible to be out, she says, but that's her looking at the event through the lens of life is horrible, because that's where she's at in her depression and her avoidance. That's where she's at. And so I know she had some good moments with her sister there. I know she enjoyed some things. I know they talked about something. They gossiped about something. They had a little laugh. Something happened that was exceptional. Now, I may not get to it, but I know it's there. But the main thing is, I know how I feel. And when I searched my feelings, I felt excited and impressed. Next, tell your feelings. We want you to tell the patient how you feel about them. And here's this lovely picture I like, in which this therapist is leaning in and telling this distraught patient how she feels about her. I really like that picture. So, you're going to tell your patient how you feel about them. And now, we're back in this place we were in with empathy. We're doing things that are very similar to empathy, that mirror empathy a lot, where in steps 4, 5, and 6, you start by telling the patient how you feel about them, right? What are those genuine feelings? And as I was just telling you, report the feelings exactly. Don't change if you think you're wrong, extreme, or upsetting. If you feel pride and you think, oh, I should say impressed, but pride sticks with you, say pride. Give that feeling the name of what's inside of you. As always, don't say anything that attacks, confronts, or criticizes. Your patient is vulnerable. They're in that regressed emotional state. They are little children, emotionally, not in their adult thinking mind, but they're regressed. They're in a place where if you are hard on them and attack them and criticize them, it can be very damaging to them for someone in your position, a caring person, to do that. And like with toddlers, if they do something really wrong and bad, you say, oh, come with me, you can't do that. You know, you kind of got into something you weren't supposed to get into, and now there's chemicals all over the floor, and your hands are getting kind of looking like they've been burned a little bit. This is really bad. Come, let's clean you up. Let's do all this. No need to cry. We're going to fix you. It's okay. Then, an hour later, 2 hours later, you sit down with that little toddler and you say, so did you know that it hurt you when you got into that cabinet? Yeah, I know. Yeah, and that's my fault too. I should have locked that thing up, and the last time I got in there, I didn't lock it up. So I have to lock it up better, so I've got to do better. Yeah, you should have locked that up because that hurt, right? And I want you to do better too, and if you ever see that unlocked, I want you to come tell me, right? Yeah, that's what I'll do. I'll tell you. Okay. Now you've had the talk. Now you've done the confrontation, but not in the heat of that moment. We don't want you saying anything that criticizes. And even though it doesn't seem like it, you can actually be critical when you're esteeming somebody. Sounds strange, but you can say, boy, you did that so well. I thought you'd never change that. I thought you were going to keep doing that the rest of your life. Well, that's no good. It may sound like, hey, you've done something really good here, but that's a criticism. That's a put down. I thought you were going to do that the rest of your life. No, you don't go doing that. So we want you to be careful that this has a lot of purity and clarity to it when you're esteeming. Use I statements. As with empathy, they're personal and they're connecting. You statements make you an authority, right? We don't want to go down that road with esteem any more than with empathy. Now, this is a little different than empathy, but what we want you to do is we want you to ask, what was different that you were able to do that? And this is a technique that is called attribution in other methods. But what it is you've done something different and better. I've seen that particular behavior. And now I want to find out if you can tell me what was different that you were able to do that. And the patient has to sit and think usually, and it's like, well, I guess it's that my partner wasn't at home and I wasn't feeling all anxious and uptight. So what was different may be something external. And you can say, well, that's great. I'm glad it worked out for you. So that's a good thing. But it seems to me that if your partner was gone, you could still feel anxious and uptight. I mean, that's happened before, hasn't it? Yeah, I guess you're right. So what was different about this time that your partner was gone? That's a good question. Well, it's going to sound weird, but I just had this really good thing happen at work. I mean, they're actually considering me for more responsibility and a promotion, and I think I was feeling more confident. Okay. Well, that's a good thing, right? Yeah, that is a good thing. So what we're doing is we're taking that exception that we have positive feelings about, and we're tracing it back to something within the patient, some form of activation, of waking up, of capability, of competence that is coming out of them. And we want to trace it back and attribute it to that particular quality within them. Because if they find that quality, oh, confidence helped me do this thing, we can keep going back to confidence. Were you confident in that moment? We will say in a later session, I guess I was. And they can keep coming back to confidence. So we want to attribute the exception to something in them, some capability or quality. So I want to tell you something. I feel pretty excited that you went out for this dinner, and I feel impressed with you that you actually went out with your sister, given how shut in that you've been.
Well, don't get too excited. I had to take a Xanax to get out the door.
Yeah, I mean, I know you still need Xanax. That's okay. But it still would have been easier just to hide at home. It would have been easier to get delivery. But you went out with your sister. I mean, that's pretty big.
She supports me. She doesn't put me down like everyone else.
I know. She's so good to you. I just really like how she treats you. I really appreciate her for that. But I got to ask another question, okay? What's different that you were able to go out to dinner at a Thai restaurant? What's different?
I got angry with my disease. I'm so tired of being sick.
Okay.
I just want to get better.
Yes, I see it. I feel it. I see it. And you got angry at your depression and your avoidance.
I hate it.
Yeah. I'm feeling more excited. I think feeling angry at this disease is a really strong step for you.
Yeah.
Really strong. I want to point out something, and that is she is making good eye contact with me. Since we started this whole thing, she's been looking down, avoiding my eyes, and that is typical of avoidant personality disorder. And now she's making eye contact. What has happened? A couple things have happened. First, she has done something exceptional, and I've esteemed that. But she kind of threw it away. No, I still needed Xanax. Don't give me too much credit. I stuck to my guns. No, this is pretty big. But I didn't stop there, did I? I asked, what is different that you were able to do this? And what I found is that she is angry at her disease. Outstanding. That's a very logical and potent and strong emotion, to be angry with her disease. And so as she talks about it, you can see she's sick of this. She hates it, but she's been trapped in this avoidant depression for a long time. But now something is breaking loose, and I saw it, I esteemed it, and I asked why it's there. And if you follow those steps, you will get this kind of response from someone who's avoidant, or from any PD. See it, talk about it, tell them you're impressed, and ask what is different that it's there. Step 5, ask, did you let that in? So if you think that getting empathy into your patients is hard, well, Esteem is harder. Because when they walk in and they're feeling really bad, they want someone to notice how hurt they are, and that empathy, they'll kind of let it in. But most of our patients have a very difficult time accepting this kind of care, Esteem, because it's so vulnerable. To be polite, they will often say thank you, but their walls will stop that Esteem from coming in, from entering their heart and healing them. They might let a little empathy in, but letting that Esteem in is going to be very hard for them, very often. So, asking the question, did you let that in, exposes their defensive walls and reveals their inability to accept the Esteem, to accept the care. This is good learning, and we'll capitalize on that. I'll say, did you let that in? And they'll say, well, no, not really. I'm not good at taking compliments. I'll say, well, okay, what is it about that? I don't know, I just don't like it. And I'll say, you're kind of turning away. It looks like you kind of turn away from compliments. Yeah, I just don't like them. And you bat them away when they come. Yeah, I just don't like them. Okay, well, that's something I think we'll want to work on, because I have good feelings about you often, about the things you're doing. I have feelings of respect, and I'm impressed with what you're doing. And when I can't deliver those feelings to you, something about our relationship doesn't get to where it needs to go, to the kind of the honesty and the reality that we need to get to. So I think we're going to have to work on that. And what I've done there is I've turned it into a relational problem, not a problem with you. Our relationship, which can heal you, is never going to fulfill itself if we can't accomplish this thing. So we'll work on it so really we can get closer. And that's the thing PD people are usually most afraid of. Now, occasionally, PD people can accept care. If so, it's a good sign. Therapy might go easily and quickly. And I was mentioning this in the Esteem lesson. One of our therapists has a borderline patient, and he can just accept care. And that means he can accept empathy and he can accept esteem. And this person is flying. They're 4 months into therapy and his life is turning around. This will be a very brief therapy because he doesn't have that blocking. Now, there are some people that can let it in, but most PD people simply cannot do it. It's not their fault. We must do something to help them do it. It doesn't fall to them to fix that. We have to do our job, earn our money, and find a way for them to break down this defense. Well, Sarah, I hope you're noticing that you've made me pretty excited.
Yeah, I can see that.
Mm-hmm. So, I have a question for you, another question. Do you think you let in my respect that I'm feeling for you right now for what you've done?
No, I don't like compliments.
Mm-hmm. I know. How about when I got all excited that you were angry with your disease?
Maybe a little.
Okay. I'll take a little. Now, this is a rather short step, but it's a very important step because when you ask that question, you open up the eyes of the patient to see that there is a block between them and you, the therapist. And the healing connection is what will make them well. And so that block has to go away. So we want them to know this. And sometimes they say, yeah, I let it in. And like I was telling you before, things go very well. But in this case, Sarah says, no, she didn't let it in. And I want her to know that. I want her to know she didn't let it in. I want it to be a known reality between us in our relationship. And so I asked the question, and she says that. But then I push a little harder, and as you see, the more active she gets, the more confident she gets, the more irritable she gets. I mean, when she's irritable, she's got some energy, right? She's got some strength. The more that happens, I'm able to push a little harder. So I've got to gauge how hard I push very carefully. If I had pushed this hard and been kind of pushy at the beginning of the session, I could have caused her to shut down completely. So I've got to gauge it carefully. But no, she's getting some energy, some irritable. She's even a little irritable with me. That's great. I don't mind that because that means there's some energy in our connection, in our relationship, right? So I'm going to let that happen. But the main thing is I now know that she did not let that in. She knows that, and we can move on to the next step. Step 6. Negotiate internalization. Accepting or letting in care is essential for the PD person. Esteem, empathy, they've got to be able to do it. But after childhood trauma, they usually are capable of letting in pain, but very little positive. Now, how do we know they can let in pain? We know this because most PD people continually choose partners and friends who cause them pain. One more time, they'll choose a partner who is abusive to them, a partner who ignores them, a partner who puts them down, a partner who makes fun of them, a friend who won't show up until the friend needs something from them, a friend who is always borrowing money and other things and not giving it back. Our patients continuously walk in with these kinds of relationships, so we know they're letting in the pain. But letting in the positive is much more difficult for them, right? So, letting in care means letting you in. If they can let that care in, they're letting you in. They're internalizing you, and this is essential for them to heal. Right? So, if we ask, did you let that in? And they say, yes, I did. We just continue caring and giving them esteem and empathy and pouring it on. And that's what Alan is doing now with his patient. If they say no, we ask, do you think it might help if you did? And the answer is almost always yes. And then we ask how. How would it help if you let my positive feelings in, if you let my esteem come in? And they'd say, well, I mean, I'd feel better about myself. What do you think? I'd have more confidence. I'd have more self-esteem. I mean, okay, that's good. So you know it will help. So it sounds to me like it makes sense for us to keep trying to do that, right? Yeah, this is really hard. Therapy is hard. They'll say, yes, it is hard. It is hard to let somebody treat you well when you've been treated poorly your whole life. That is hard. I'm not stupid about that. But let's keep going, yeah? Let's keep doing this. And now we're going to do a little bit more to open up the gates of those walls. That is, we're going to ask, did you let it in even a little? Now, this is a kind of a tricky question, and that's why we use it, because it's tricky. And that is, almost nobody is 100% one thing or another. Nobody is 100% open, right? Even if they pretend to be, they're not. And no one is 100% closed, even if they pretend to be. There's always a little bit of room in one direction or another. And in this case, when you say, did you let in even a little bit, the answer is usually yes. So you esteem this patient. You say, well, you know, I'm very impressed that you controlled your anger when I forgot the name of your partner, of your boyfriend. I'm impressed by that. And even if those walls are solid, and you'll say, did you let in even a little bit of that? They'll say, yeah, I let in a little bit, but not very much. And I would say, well, that's a good thing, right? You let in a little bit. That's good. That's a starting place. Yeah, I don't know. I don't like this. It makes me uncomfortable. Okay, it does, I'm sure. But do you think it helped you to let in even a little bit? And they'll wonder and they'll think. And sometimes on this question, they'll take a long time. They're wondering, I'll say, well, it doesn't feel good, but I guess it's the medicine I have to take. Yes, it's the medicine you have to take. This is part of you getting better, and I know it's hard, so thanks for indulging me, but I'm going to want to encourage you to let more and more of that in, right? And I've had a patient I've seen for a long time, just one of the worst histories I've ever seen, just unspeakably bad abuse throughout her life. And so the idea that she was going to sit with me and let something in was really terrifying to her. And it took years for this to happen. Nope, nothing's getting in. Don't even think about it, Diggs. It's not happening. Whoa. And so I reached a point where I would just say, well, what am I going to do with all these positive feelings I have in my head about you? Well, you can just keep them there. Okay, but you know they're there, right? You know I have a lot of positive feelings about you. Yeah, I know they're there. Well, if you know they're there, what's the difference between me saying them or not? And she would say, well, that's a hard question. I don't know the answer, but I just like it better if it's in your head. Now, a lot of sexual abuse. So part of letting someone in to her had a feeling of being sexually abused. There was no way for her to escape that. And so I said, okay, no problem. I'm just going to keep them in my head as long as you know they're there. And she said, fine. So something would move along, we'd be having a session down the line, and she would, all of a sudden I'd be sitting there having really positive feelings towards her, and I would just sit there and look at her, and she goes, why aren't you talking? What's going on? What's the big deal? And I said, well, I'm having a lot of positive feelings about you, but I can't say them. And she'd go, Can you just not have those feelings? I said, no, I can't stop those feelings. They come up in me. They're natural. You don't do something like you just did, I'm going to have a positive feeling. I can't stop it. And she'd go, And it's so cool, you guys, because over time, just knowing I had those feelings in my head, in my heart, she started breaking down. She started allowing me a small amount of room to say some things. And then the gates opened, and she's pretty well. Finally, we offer a parting out. We say, if you would like in the future, we have an exercise where we can take down your walls so that you can let in all the positive feelings that I'm having for you. And usually the answer to that is, well, I don't know about that. I'll think about it, but I like my walls right now. So as time goes on, we gradually take down those walls a little bit at a time, and eventually they're ready to have the walls come down through a parting out. So, more questions. Do you think it would be helpful to you if you did let my respect come in?
Well, maybe a little.
Mm-hmm. Okay. How do you think it might help you?
You just don't give up, do you?
Oh, you know me so well already. Usually I don't give up, no.
Of course I'd feel better.
Okay. How would you feel better? What would it be like? What would you feel like?
I think I just feel better about myself.
Okay.
I wouldn't hate myself so much.
Okay. So that's good. You'd feel better about yourself and you wouldn't hate. But that's kind of, you wouldn't hate yourself is what you wouldn't feel. What would you feel? Would you feel a love, a confidence? What would you feel?
I guess I'd feel more free.
Okay.
From all my misery.
Okay. Free. Lovely.
It's horrible.
It's horrible. But we've got a little tiny taste of freedom here, don't we?
Yeah.
I'm going after that freedom. I want that for you.
Yeah. I do too.
Good. Okay. So, this is a beautiful moment. We both feel it. Something happened where she was able to show me what was in her, this desire for freedom, this possibility for freedom. Now, for her to tell me that, for Sarah to tell me that, is a very risky thing. It's very open to tell me that this is her dream of how things would be better. And I felt emotional, even though it's just a role play doing it. Did you feel emotional?
Oh, yeah. Yeah, I did.
Yeah.
Mm-hmm.
Yeah. Touching these deep places isn't about whether it's a role play or any of that stuff. There is this deeper emotional reality that we're trying to connect. And you watched us find it right here. And because it's a role play, we might not have found it, but we did. And that's because Sarah, our actress, was able to let herself really feel what this character wants, and it's that freedom. So now we've had this taste, we've had this moment of connection, we've negotiated internalization because now we're connected. Now there's a connection between us. And from this point on, she'll relapse many times. That's no big deal. That's what personality disordered people do. They fall back into their old patterns. We don't care. Because once we've had that taste of the real thing we're looking for, we keep going for it. And we've had that. So that was a great moment.
Mm-hmm.
Nysa empathy. Our empathy is a deep relational feeling, but it is also a precise technical intervention. Your real feelings are used in a precise way, a clinical way, to penetrate the patient's walls, internalize your image, and help to create secure attachment. The marriage of relationship and technique together. And we think this is a beautiful marriage. I hope you do too.